I'm sure we'll have a few stragglers coming in shortly. But let's get started because we often have a lot to cover in these rounds. Please welcome Dr. Peng Yan, who's going to lead our grand rounds today. Dr. Yan did his medical degree at the University of British Columbia, followed by residency at the University of Ottawa. He pursued his subspecialty training in surgical retina here at the University of Toronto, and he now practices his surgical and medical retina services through Kensington Eye Clinic and the Toronto Western Hospital. He's an assistant professor in our department and a very active clinical educator. He's actively involved in training medical students, residents, and fellows, of course, and very active in research as well. But mostly, he really gets things done for our residents. I want to thank Dr. Yan for everything he does for our residency program. So thank you. And please welcome our two resident presenters, Austin Pereira and Atim Batawi. Thank you and good morning.
Hey, good morning. So I guess I can start, right? Just not taking too much time. So here we go. Can you see my slide, everyone?
Yeah, you're good.
Okay, so good morning, everyone. Happy Friday. This morning's grand round, we're going to cover a relatively new concept on the pachychoroid spectrum disorder. Something that sort of is fairly recent with advance of technology. We're able to explore the choroidal space much better with en face OCT, OCT angiography. So this spectrum of disorder plus choroidal related disorder might continue to increase as we explore these fields. No financial disclosure related to this topic. And the objective this morning is to review some of the basic concepts of choroid, appreciate the concept of pachychoroid disorder, an update on the classification of pachychoroid spectrum disorder, some of the subset of diseases, and through the use of multimodal imaging in the management and diagnosis of these mystery cases, which are a subset of pachychoroid spectrum disorder. Our two experts, Austin Pereira, PGY2, and Atim Batawi, PGY5, are both experts in these pachy spectrum disorders. They have presented in the past and have published on this very topic. So they will be leading these discussions. Now, before we go into the pathophysiology of the choroid, let's just go for a little review of the basic physiology of the choroid, which is a very important structure that previously we're not able to image because the RPE hinders the passage of the light into the deep choroid. Now with en face OCT, OCT angiography, and so on, we're able to better visualize this very structure. The choroid, as we all know, is divided into several different layers. They're not distinct, but arbitrarily, the Brooks membrane separates the choroid and the neurosensory RPE. It is this very layer that if it's breached or the integrity is disrupted, that allows the invasion of the choroidal vessel to the retina, leading to choroidal neovascularization. Then we have the choriocapillaris, which is very important in supplying nutrition to the RPE, as well as taking away the metabolites from RPE. And then we have our Sattlers and Holler's layer, and then followed by the potential space of the suprachoroidal space. Now, the function of the choroid is mainly to support the retina, more specifically the outer layer of the retina. So as we can imagine, if there's a disease to the choroid, then the RPE will be diseased, leading to disease of the photoreceptors. Therefore, various diseases, including wet AMD, PCV, polypoidal choroidal vasculopathy, CSR, degenerative myopia, and age-related choroidal atrophy are all associated with the choroid. So without giving away too much, we will get into our feature presentation. And I'll pass the baton to our retina superstars, Austin and Atim.
Thanks, Dr. Yan. Let me just share my slides here. Hi, everyone. My name is Austin Pereira. I'm one of the second-year residents in our program. As an aside, my first rounds was 5 years ago when I was a first-year med student trying to get more exposure to ophthalmology. I remember two things really stood out to me. One, how deep Dr. Lloyd's voice was, and how complex Dr. Kaplan's talk was. So 5 years later, did not think I'd be doing it in shorts, but it's a real honor to be speaking in front of you all today on a case that was initially treated as diabetic macular edema. So an 80-year-old male was referred to Dr. Peng Yan for a second opinion for persistent intraretinal fluid in his left eye. The patient had no change in his symptoms over the past 6 months prior to presentation. However, he had received 9 intravitreal Eylea injections over the course of 2 years prior to presentation. And we're really looking for help to help relieve this patient from his persistent intraretinal fluid. The patient had a past medical history significant for poorly controlled type 2 diabetes, as well as he was a vasculopath. His mother had diabetic retinopathy. And here are the exam findings. The patient was 20/25 in his right eye, 20/40 in his left eye. And most notably, you'll see these yellowish deposits kind of in the parafoveal region, notably in the left eye, as well as these grayish blue subretinal deposits or lesions pretty much along the inferior and superior arcades in the left eye. The OCT macula was conducted, and the 2 key findings were these hyperreflective foci possibly corresponding to those parafoveal yellow flecks that you saw, as well as intraretinal fluid cysts, most notably respecting the nasal macula, respecting the fovea. Fundus autofluorescence was also conducted with multimodal imaging, and you can see this stippled hypo and hyper autofluorescence, as well as this pattern of kind of gravitational tracks in the left eye, most notably respecting the nasal macula. And fluorescein angiography was conducted, which shows staining throughout the macula, primarily along the superior and inferior arcades in the left eye. So to summarize so far, we have an 80-year-old male with poorly controlled diabetes, initially treated with intravitreal Eylea anti-VEGF injections times 9 in both eyes over the course of 2 years. OCT showed really stable intraretinal fluid, most notably in the nasal macula. Wide field photos showed exudates of the macula and intraretinal fluid. And fundus autofluorescence showed those gravitational tracks of stippled hypo and hyperautofluorescence. So with this information, what is the initial diagnosis in this diabetic patient? Would it be diabetic macular edema, neovascular age-related macular degeneration, peripapillary pachychoroid syndrome, or cystoid macular edema? I'll let the answers roll in.
All right, Austin, I'll end it here.
Awesome. Wonderful. So it looks like 88% of people read the title of the talk, so that's wonderful. And we'll go on to the next question. How would you treat this patient? The 4 options are, would you observe this 80-year-old gentleman as he's already received intravitreal injections, nothing else to do, just observe? Would you initiate photodynamic therapy? Maybe switch up therapy for this gentleman. Would you continue intravitreal anti-VEGF injections and possibly switch maybe Eylea to Lucentis? Or would you initiate panretinal photocoagulation?
We'll give it another 5 seconds or so.
Awesome.
A bit of more of a split here.
Wonderful. Okay, so people initiate photodynamic therapy, and then second is observe, and 1/5 would continue intravitreal anti-VEGF injections. So wonderful, great topic for discussion. So the next question we really asked ourselves was, what imaging would we want to do next? And by we, I mean Dr. Yan. And Dr. Yan astutely decided, some of the fluid is really localized at the nasal macula respecting the fovea. Let's get a 5-line raster OCT along the peripapillary region in the right and left eye. And here are those peripapillary OCTs. You can see that the course of the image goes from inferior to superior rather than nasal to temporal. And you can see here throughout the peripapillary region, there is this localized intraretinal fluid throughout, most notably in the outer and inner retinal layers. But when you look closely at this EDI OCT, you can also see that there is a fairly enlarged choroid, really engorged Haller's layer that Dr. Yan described in his initial talk, as well as an overlying choriocapillaris, which is quite attenuated and compressed by the underlying Haller's layer. And if you look back at the OCT macula, I described this hyperreflective foci in intraretinal layers, these intraretinal cysts of fluid, but also you can convince yourself that there's also an enlarged Haller's layer. Let's get out our calipers on our OCT sites that everyone uses. And if you measure the entire width of the cornea, it's actually 340 microns, which is quite large. Normal is around 260 to 300. So what is the actual diagnosis in this patient? It is peripapillary pachychoroid syndrome. Peripapillary pachychoroid syndrome is a relatively new diagnosis introduced in 2019. It is a variant of the pachychoroid disease spectrum, which I will outline in the coming slides. It is characterized by localized intraretinal and or subretinal fluid in the peripapillary region, respecting the fovea localized in the nasal macula. Pachyvessel engorgement leading to choroid capillaris attenuation is the hallmark for all pachychoroid disease spectrums, but one of the helpful keys for the diagnosis are choroidal folds. And there's association when we did a literature review with hyperopes and patients with discs at risk. This is not at all related to diabetic macular edema. The diabetes in this patient was a red herring. Pachychoroid disease spectrum was first introduced in 2013, and I know Dr. Raya was joking that he didn't really have this in his residency training, so if you haven't heard about it, it's all good. It's a relatively new diagnosis that was introduced by Waro et al. And has been taken up by Spade et al. In the recent years. It is a constellation of pathological states that are characterized by a thickened choroid. Multimodal imaging has now really changed the game with how we characterize pachychoroid. Rather than just a thickened choroid, it's really an engorged Haller's layer, a compressed Sattler's layer, and overlying choriocapillaris attenuation. The underlying etiology of pachychoroid disease spectrum is still unclear though, but right now our current thought is that there's an association with the vortex veins in the eye and their congestion leading to anastomoses between vortex veins and leading to backflow and choroidal congestion. Now, I think people are sick of seeing this picture of pressure and resistance from grade 11 physics, but Spade et al. In 2020 compared choroidal flow to resistors, sort of analogous to cerebral venous circulation. If you think of vortex veins as a resistor to the eye, if they are increasing resistance, there'll be increased back propagation of pressure towards the choroid, leading to engorgement of the Haller's layer and pachychoroid disease spectrum. And this asymmetry in choroidal venous outflow can lead to various pachychoroid entities. So really the key thought right now, it's an anastomosis between vortex veins that serves as a decongestion mechanism for increased pressure, and this remodeling leads to pachychoroid disease spectrum. Future investigation is, well, where does that resistance actually occur? In the vortex veins, possibly in analyzing the sclera as a site for where the vortex veins are experiencing those high levels of resistance. And also, why do some pachychoroid disease entities have neovascularization and some, like peripapillary pachychoroid syndrome, do not? Pachychoroid syndrome, apologies, is a spectrum. It ranges from uncomplicated pachychoroid all the way to polypoidal choroidal vasculopathy. And in between, you have entities such as PPE or pachychoroid pigment epitheliopathy, which is earlier entity of central serous retinopathy, which we all know. And we have pachychoroid neovasculopathy with or without neurosensory detachment. You can also group pachychoroid disease spectrum into three main categories. The first being exudative, and that's where peripapillary pachychoroid spectrum falls within, as well as CSR and focal choroid excavation. You have the atrophic entity of pachychoroid pigment epitheliopathy, which was the first ever pachychoroid entity described in 2013. And then the two neovascular entities, PNV and PCV, which Hatem will be describing shortly. Now let's go back to our case, peripapillary pachychoroid spectrum. If you look back at the fundus photo, you have these exudates at the macula. And if you look closely at those grayish blue lesions, those are really intraretinal fluid pockets that are primarily in the peripapillary region. But there's also reduced fundus tessellation, which has also been described in these patients. OCT has a thickened choroid with choroidal folds, intraretinal fluid respecting the fovea, and you can also have varying amounts of subretinal fluid. But as I mentioned, no CNV. Fundus autofluorescence has that modeled hypo and hypoautofluorescence with gravitational tracts, which is the key finding in fundus autofluorescence. And fluorescein angiography has sometimes diffuse leakage. This patient did not have as much, as well as peripapillary staining. But now the key question, question number 2, how do you treat a patient such as this with peripapillary pachychoroid syndrome? Well, Zhu et al. In 2020 did a great study looking at the long-term outcomes in these patients. either having anti-VEGF injections, photodynamic therapy, or observation. And there was no significant difference in visual outcomes at 6 months in these patients when they are observed conservatively versus receiving laser or injection therapy. So this can save patients from unnecessary intravitreal injection therapy, the morbidity that comes with getting poked in the eye every month. And so the outcome when Dr. Yan initiated observation was there's no change in vision 6 months after observation. The patient remained at 20/40. So just to tie off my talk, I want to just touch upon the atrophic version of pachychoroid disease spectrum, pachychoroid pigment epitheliopathy. As I mentioned, this was the first ever pachychoroid entity described by Ware et al. In 2013. It is characterized by all the pachychoroid entities, the engorged Haller's layer, compressed Sattler's layer, and choriocapillaris attenuation. But the hallmark is this RPE atrophy and modeling, these little RPE changes, which are quite subtle if you're not looking for them. There's no underlying neurosensory detachment. The interesting thing about this case and this entity is that it may represent an earlier precursor to central serous chorioretinopathy. In a study by Erzos et al. In 2018, they found that 61% of patients with unilateral CSR had pachychoroid pigment epitheliopathy in the other eye. So it'll be interesting to get an OCT in those unilateral CSR patients to see if they are at risk of CSR in the other eye. And again, the OCT findings in this are small PEDs, RPE abnormalities, and underlying choriocapillaris attenuation due to the engorged Haller's layer. Thank you all for listening to my talk, and I'll pass it off to our 5 superstar, Hatem.
Perfect. So Austin, great job, great talk. And as we get Hatem's talk loaded, there is a question from the audience. I think it's Brad Capes, and asks if there's any role for spironolactone in these cases.
Yeah, great talk. I actually heard that Dr. Spade is running a study on spironolactone right now. There's no evidence of spironolactone at this time. However, because of its use of, possibly in CSR, there's a thought that it could work. So no primary evidence yet, just anecdotal.
Perfect. Thank you. Great job, Austin.
Excellent talk. Can you elaborate on the coloration of those blotches? You said they were the sort of purplish bluish things. Why is the fluid causing that color?
Yeah, great question. Dr. Yan and I were surmising it was due to the chronicity. Because as I mentioned, the patient's had this intraretinal fluid for about 2-3 years, hasn't really moved. It could be due to the pigment changes that occur in the intraretinal deposits of those intraretinal cysts. Definitely interesting though that it was kind of that grayish blue color for sure.
All right, Hatem, you're up.
Hatem, slides are up.
Perfect. You can see my slides.
Yes.
Yep. So good morning, everyone. My name is Hatem. I'm one of the senior residents. And first of all, I would like to thank Dr. Yan for helping me with this case. So here we have a 65-year-old male Asian patient who presented with progressive decrease of vision in his right eye for many months. The review system was unremarkable. Vascular history was significant for cataract surgery 10 years ago, and the patient was high myope. Past medical history significant for hypertension, diabetes, and dyslipidemia, and the patient was taking medications for these diseases. Socially, he was a past smoker, and he has no allergy to medication. On examination, the vision in the right eye was 20/100, in the left eye 20/25. Pupils, IOP, and slit lamp exam were completely normal in both eyes. Dilated fundus exam in the right eye, as you see here, there was an orange yellowish lesion inferior to the fovea with some exudates and large central serous PED. Left eye fundus exam was completely normal. What about OCT? The most striking feature you're seeing here in the OCT scan for the right eye was the large multiple PEDs with some subretinal fluid and intraretinal fluid. OCT for the left eye was completely normal. So now we're gonna launch the first poll. The question is, what's the most likely diagnosis? Number 1, diabetic retinopathy with macular edema. 2, CSR with CNBM. Number 3, it's a RAB lesion. Number 4, PCV. Number 5, AMD with the CNVM.
All right, Hatem, we'll give it a couple seconds to let the results come in. But it seems like there's an overwhelming majority for polypoidal.
Okay, perfect. So most of the audience picked PCV, which is the likely diagnosis. Okay, so I'm not sure it's freezing. Yeah, perfect. So based on the clinical presentation and OCT imaging, the most likely diagnosis was PCV. However, our differential diagnoses include chronic wet AMD, chronic CSR with CNVM, pathological myopia with CNVM, and choroidal tumors or metastasis. The second question is, what's the most appropriate next step that will help us to diagnose this condition? Number 1, should we do on-fast OCT imaging or OCTA or fundus autofluorescence or IVFA or ICGA?
Amazing how many choices you have. So let's let it run for a couple more seconds.
Okay, and as expected, most of the audience picked ICGA. All these imaging actually can help to diagnose PCV, and we will go over them in details today. So just a quick overview about PCV. It's a disease of the choroidal vasculature first described in 1990s by Dr. Januzzi, which is characterized by abnormal polypoidal dilation in choroidal vasculature associated with detachments of the pigment epithelium and exudative changes that can lead to subretinal fibrosis if left untreated. The etiology is not clearly understood. Risk factors include smoking, obesity, elevated C-reactive protein, interleukins 1 and 23, commonly diagnosed between the ages of 50 and 60 years, earlier than AMD, which is an important differential diagnosis, more common in Asians compared to Caucasian, and marked male predominance, and only 6 to 24% presented with bilateral involvement. What about the pathophysiology? It started with branching vascular network that infiltrates into the proximal membrane and terminates in polypoidal lesion, as you see here in the picture. When the exudates of the polypoidal lesion increase, fluid from the polypoidal lesion accumulates in proximal membrane, resulting in serous PED and subretinal fluid, as you see here in the picture. Also, fluid from the PCV lesion infiltrates under the polypoidal lesion itself, and the polypoidal lesion detaches from proximal membrane and choroid, and that leads to multiple PEDs. And again, as you see here in this diagram, the abnormal polypoidal vascularization in PCV are identified between the elevated RPE and proximal membrane as a variant of type 1 neovascularization. What about location? PCV usually located at the posterior pole, mainly in the macular or peripapillary region, and can be classified based on location to subfoveal, juxtafoveal, extrafoveal, peripapillary, and peripheral PCV. What about presentation? It can be presented as orange reddish pulp-like lesion budding from choroid into the subretinal space, or exudative or serous PED, hemorrhagic PED, hard exudates, and rarely present as breakthrough vitreous hemorrhage, and in this stage usually present as subretinal fibrosis. What about clinical classification? It can be quiescent, so the patient has polyp in the absence of any fluid or hemorrhage, or it can be active. The patient has exudative changes or hemorrhagic changes, or could be mixed hemorrhagic and exudative. What about imaging modalities in PCV? We can do invasive tests like IVFA and ICGA. Also, non-invasive testing can be done like OCT, in-pass OCT, OCTA, and fundus autofluorescence. IVFA is not very useful for PCV because of the inability to the FA to visualize sub-RPE structures, including polyps and choroid. PCV appears as occult CNVM on IVFA, and the polyps are rarely visible. The key characteristic of PCV on IVFA is the presence of branching vascular network vessels terminating in grape-like clusters, as you see here in the picture. What about ICGA? ICGA is the gold standard investigation tool used to diagnose PCV. Single or multiple polyps can be seen in the early phase of ICGA with or without the branch vascular networks. PCV is classified into two subtypes according to the appearance on dynamic ICGA. Type 1, the polypoidal type, caused by abnormalities in choroidal vasculature. And we can see polyp and BVN, as you see here in type 1. Picture, and in type 2, which is the typical PCV type associated with choroidal neovascularization, and here polyp can be seen only with absence of BVN, as you see in the second picture. And this slide just showing the PCV diagnostic criteria as per the Japanese study group guidelines and as per the Everest study guidelines. As you see here, both guidelines were based on ICGA findings. So you have to have ICGA done to diagnose the patient with PCV. What about OCT? The typical OCT features in PCV include sharp peak PED, also described as stem-like protrusion. And also we have sub-RBE ring-like lesion, as you can see here in the second picture on your right, which is a round structure seen under the PED, may have hyporeflective center and hyperreflective outline. Also, we can see complex or multilobular PED, also described as notch PED or the double hump sign, as you see in the left picture. Also, we can see double layer sign in the right picture, which may cause by either separation of the RPE from the prox membrane or separation prox membrane from the choroid. And as we mentioned before, thick choroid with dilated halar layer vessels can be seen. And in this case, the subfoveal choroid thickness should be more than 300 microns. Also, we can see fluid compartment. Most likely, I would say we will see subretinal fluid, but occasionally and rarely we see intraretinal fluid as well. What about on-fast OCT? The PCV lesions are typically seen as elevated RPE rings with inner reflectivity with or without a branching vascular network. And as you see here in the picture, the polypoidal lesions detected on on-fast OCT generally correlate very well with the lesions seen in the ICGA. What about OCTA? It can provide anatomical information about polypoidal structure, and it can detect both the branching vascular networks, as you see here in the black row, and polypoidal lesion, as you see here in the white row. The detection rate of polypoidal structure is lower than ICGA, and recent studies show that OCTA might detect more branch vascular networks and fewer polyps compared to ICG, and only about 50% of polyps were detected by OCTA. In terms of autofluorescence, the polypoidal lesions typically seen as central hypoautofluorescence with circumferential hyperautofluorescence ring, as you see here in the picture, and the branch vascular networks usually seen as a granular hyperautofluorescence, as you see here as well. So we're going to go back again to our patient and our question. What's the most appropriate next step to do? Most of the audience picked ICGA. But before answering this question, let's talk about PCV in Canada. So this is a very interesting paper where was recently published by Dr. Lam and Dr. Wang that focus on PCV in Canada. And they highlighted that the PCV appears to frequently underdiagnosed in Canada due to ICGA not being performed routinely and due to PCV not being considered by ophthalmologists, particularly when managing Caucasian patients. And the ICGA was used to confirm the diagnosis of only 20% of the Chinese Canadian patients and 8% in Caucasian Canadian patients whose eyes were labeled as having PCV. So although the ICGA is very important diagnostic tool, sometimes it could be not easily accessed. So the most important question here, can we diagnose PCV without ICGA? This is a recent study highlighted the role of OCT to diagnose PCV without using ICGA. And they highlighted that the non-ICGA diagnostic criteria, which can serve the need for most clinical situations, allowing for a quick, practical, and non-invasive method for diagnosing PCV, especially in clinical settings and practices that don't have access to ICGA. They highlighted 9 important criteria or features usually seen in PCV patient using OCT and clinical exam only without ICGA. And the 3 major criteria were the sub-RPE ring-like lesion, on-fast OCT complex RPE, and sharp peak PET. And 6 minor criteria including orange nodule that can be seen on clinical exam, complex or multilobular PED, thick choroid, double layer sign, extensive subretinal hemorrhage, again, can be seen on clinical exam, and finally, the fluid compartment. And this slide just to remind you about the OCT imaging and the fundus exam features, the major and minor features that associated with PCV. And also in this study, they reported that if the patient has 3 major criteria and any one of the minor criterion, the sensitivity and specificity and the positive reductive value for detection of the PCV will be quite high, almost 90%. And let's go to our patient again. So the fundus exam showed the orange nodule, the OCT showed thumb-like PED, the ring-like lesion, thick choroid, double layer sign, notch PED, and subretinal and intraretinal fluid. So for the next imaging modality, we decided to go with the on-fast OCT, which showed complex RPE elevation. And as per the non-ICGA diagnostic criteria, this patient has 3 major criteria and 5 minor criteria, and based on that, the likely diagnosis was PCV. What about the treatment? The treatment of PCV is based on the location and the activity of the disease. Signs of activity include presence of intraretinal fluid, subretinal fluid, hemorrhages, and vision loss. And the general rule is for active and symptomatic PCV, we should treat. For active and asymptomatic PCV, we can consider treatment based on the circumstances, but for inactive PCV, we should observe. And the treatment options include observation, as we mentioned before, for inactive PCV, photodynamic therapy for active subfoveal or juxtafoveal polyp with BVN, thermal laser photocoagulation, usually for isolated, very small extrafoveal peripheral polyps. Intravitreal injection of anti-VEGF therapy can be used for active prepapillary PCV or polyp extent not clearly defined by ICG. And finally, combination therapy. Let's go over the clinical trials or the major clinical trials done in PCV. So this is the laptop study, which is a phase 4 prospective multicenter randomized trial compared the effect of BDT monotherapy versus ranibizumab monotherapy in PCV. And they reported that at month 12 and 24, patient in the ranibizumab monotherapy arm achieved better visual outcomes than patient in the BTT monotherapy arm. However, the Everest-1 study was the first randomized controlled trial in PCV that compared the efficacy and safety of anti-VEGF monotherapy, BTT monotherapy, and combination therapy. And they reported that BTT in combination with ranibizumab and BTT monotherapy showed a significantly higher proportion of complete polyp regression at 6 months than the ranibizumab monotherapy group. Similar to Everest-1 study, the Everest second study supported the combination therapy, and they reported that combination therapy for ranibizumab plus BTT was superior to ranibizumab monotherapy in best corrected visual acuity and complete polyp regression. However, they reported significant visual acuity gain in the anti-VEGF monotherapy arms at 1 year, but not superior to the combination therapy. And this is another study. The Fujisan study was a randomized controlled trial in PCV, which evaluated initial versus deferred BTT combined with ranibizumab, and they reported that both the initial and deferred BTT combined with ranibizumab to treat PCV show the similar visual and anatomical improvements at 12 months. Initial BTT combination leads to significantly for additional treatments and injection. What about the PLANET study? The PLANET study, actually, they compared aflibercept monotherapy with or without rescue BTT, which was available after 3 months. And they reported that improvement in visual and functional outcomes was achieved in more than 85 participants who were treated with aflibercept monotherapy. And the potential benefits of adding BTT cannot be determined. And recently, another study published just a few months ago highlighted the role of the new anti-VEGF therapy, the brolucizumab, in PCV, and they reported that the 3-month outcomes of type 1 CNV patient, including 19 patients with PCV treated with 3 loading doses of brolucizumab, showed polyp regression in around 80% of cases, combined with visual improvement and anatomical outcomes. So the take-home message is ICGA is the gold standard investigation tool to diagnose and confirm PCV. Multimodal imaging, especially OCT and on-fast OCT, can be helpful to diagnose PCV if we don't have access to ICGA. And the most important goal of treatment of PCV should be achieving the best possible visual outcome while minimizing the treatment burden. And both anti-VEGF monotherapy as well as a combination anti-VEGF therapy and BTT are acceptable initial treatment options in patients presented with symptomatic PCV. And thank you.
Very nice presentation, Adam. First question. So does PCV have a race or sex predilection or not? You mentioned how it's underdiagnosed in Caucasians. Is it actually equal across the board and we just think it's associated? What's the story on that?
Yeah, it's more common in Asian ethnicity. And also when like we look to the literature, Caucasian actually, if we think about the sex in Caucasian, male and females, it should be like equally common, but in Asian people, we should think about males only, like usually common in Asian males. But if we think about Caucasian, like both gender, male and female should be equally, I would say.
Thanks, Hatem. And there's another question for you. If you could go back to the OCT, are you able to demonstrate the ring-like lesion?
Yeah, sure. Give me 1 second. So, you know, the ring-like lesion here, it's not very obvious, but if we see here, there is like, again, hyper-reflective outline with some hypo-reflective signal inside this lesion. So we think that this is the most likely the ring-like lesion here in this area.
Adam, can you use your mouse or something to show us? I don't know what you're showing.
I'm using my mouse, but I'm not sure.
Showing up, eh? Okay.
Okay, so sorry, we're gonna go here. Yeah, so you can see the arrow here. So I think this is the ring-like lesion. Again, you can see some hypo internal reflectivity with some hyper like reflectivity outside. Yeah, again, it's not very clear, not very obvious.
If you leave the arrow out, Hatem, I think people can appreciate it a little bit better. If you look at the tip of that PED, it's a bit peaked. That's number one, right? It's slightly peaked. Number two is within the consistency of this is a little bit heterogeneous. Superiorly at the tip of that PED, there's this sort of more little hyper reflective ring. I do have an example I can show you. But what do you think this is? This Jason sent you ask. I guess we can't ask him the question, but this lesion here is actually the polyp, and so that's why it's a peaked PED with what they used to call a thumbprint sign. So the thumbprint sign, this thumbprint is actually this polyp, and is pretty pathognomonic for it. And in between the two PEDs, you have thickened Brooks membrane with a double layer sign. What's distinguished the PED of PCV from other choroidal neovascularization is what Hatem has very nicely demonstrated in his pictures. The vessels from the choroid, not like your traditional wet AMD, it does not break through RPE. it penetrates within Brooks membrane. And Hatem, if you want to go back to that picture that you have with the pathophysiology, and it forms this vascular network between Brooks membrane RPE. And therefore, you rarely get intraretinal fluid, but mainly subretinal fluid, because the RPE is not breached. And then it forms this little terminal bulb, and it leaks between the Brooks and PE and RPE, leading to a neighboring serous PED formation. So that's what's unique about this, right? So you have your choroidal vascular network branching somehow into Brooks and underneath the RPE. And that's where it forms this little peak PED with a thumbprint sign. This terminal vessel polyp then leaks. And as it leaks, the fluid goes to its neighboring PED, causing a neighboring larger PED. So the larger PED is not where the problem is usually adjacent to it, where you find this orange polyp. And that's why when you say this ring-like lesion, is thumbprint, either you call it thumbprint sign or a ring-like lesion is where the aneurysm is. Is this also related to vortex vein congestion? Hatem, did you want to give it a shot?
So again, all pachychoroidal diseases, it could be related to choroidal or vortex vein issues, but in this case, I would say the most abnormal things that we can see here is the branching vascular network, and the etiology for the branching vascular network development is unclear.
Yeah, but it still remains within this pachy spectrum disorder. And when people talk about pachychoroidal disease, it means, although it literally means thickened choroid, but most predominantly, I think Austin and Hatem addressed, what's the pathology mainly lies in enlarged Holler's layer, leading to compression of the smaller vessels, like the choroid capillaris. And that leads to the defectiveness of the RPE. And so the whole spectrum actually, see, this whole spectrum disease is actually slowly expanding. So if the RPE goes sick, then the photoreceptor goes sick. Then you first lead to RPE changes, and there's a new addition to the list of drusins, right? There are many drusins, but there's addition, and it's called pachydrusin, and it's associated pachychoroid, which is part of RPE defect. So you have pachydrusin, RPE sickness, and then that leads to your CSR, right? Because RPE can't pump all the fluid. From there, you can get pachychoroid CMVM, and then you can get PCV. And so the list goes on, but it's triggered or associated at least with thickened or diseased choroid. And so hopefully with more imaging modalities, the more we can visualize the vascular network, the better we can explain these.
Perfect. Thank you, Peng. Another question for you guys. Are there times that the polyp might cause subretinal fluid?
The polyp should always cause subretinal fluid. It should always cause it can cause subretinal fluid, but rarely intraretinal fluid because the intact of the RPE. But occasionally you can, as what Hatem's case demonstrated. There's presence of intraretinal fluid. In fact, the PCV looks very similar to, if you look on just purely OCT, sometimes they look very similar to a RAP lesion. They all have these large PED. The difference is what Hatem has demonstrated, multiple peak PED, multiple PEDs, multi-low PEDs. Whereas in the RAP lesion, there's a particular shape to the PED, which is usually like it's got multiple edges, or like almost like a pentagonal shape to it, and it's more flat instead of a peak PED. But in RAP lesion, you definitely see a lot more intraretinal fluid because the origin is intraretinal. Can I share my screen so I can show you a really nice picture of the ring-like lesion? Before we finish, unless anyone else have a good question to ask. Here we go. So here it has all the features of a PCV, right? So you can probably see where the ring-like lesion is. Remember, this is where the problem is. This is where the pathology is. And it is this lesion that's causing the fluid buildup adjacent to it. And you can imagine the blood vessels probably penetrate, and there's that sort of little divot between the multiple lobes of the PED. And then you have your thickened Brooks membrane, even on the other side. Right? And then, of course, you have Pachy vessels. So the Haller's vessels are very large. In essence, they're sort of compressing above capillaries. So there's for Jason, just for him, there it is, the ring-like lesion. Any other questions?
Hey, that's a great picture, Peng. There is one question not related to this, but maybe Austin's talk. Similar to spironolactone, any evidence for eplerenone?
Yeah, that's a great question, Dr. Lichter. And thanks for relaying it, Dr. Rai. None as of yet. There's a couple of studies that are currently ongoing for peripapillary pachychoroids specifically. One of them, as we mentioned with Dr. Cates, was spironolactone, and one is photodynamic therapy. And finally, there's early evidence to show that some steroid use could also work. However, that's still up for debate. So those are the three main areas of further research in the treatment of peripapillary pachychoroid syndrome. But as of right now, just observation is the only accepted method in primary literature.
So Austin, you mentioned that this spectrum is changing, or formerly known as, I mean, are we changing our terminology now? Do we not call it PCD anymore? How is this going to change the rubric and the classification of these conditions when we talk about them?
Yeah, that's a great question. As of right now, we just need to find more information as to the etiology of these diseases so we can really characterize them on a spectrum. So as of right now, we kind of go from an atrophic to an exudative to a neovascular entity on the spectrum. And I believe that PCD is on its way out, and we will kind of go to an aneurysmal type 1 for the further classification. So as Hatem was mentioning, more ICG research and imaging, as well as finding why these vortex veins get these anastomoses in these patients, will really elucidate where these entities fall on said spectrum. So I think more information will come in the coming years, just how this whole area has changed in the last 8 years alone.
Personally, I hope
it really is incredible to see that.
It's easier to say.
Yeah, 100%.
It's really incredible to see these advances in this area. There's another question here from Nancy Epstein. How would the choroidal folds present on OCT? Are they present in PCV, and what's the relation to hyperopia?
Yeah, that's a great question for the hyperopia related to peripapillary pachychoroids, and specifically. Unclear what the relationship is. Maybe it's just more of an association, and maybe just kind of a sample bias there. The discs at risk, again, is an area which was very interesting in literature review. Our patient had disc at risk. In this study in 2019 that introduced this entity, 68% of the patients had disc at risk. Again, no proposed pathophysiology. I wonder if our neuro-ophthalmology gurus can maybe surmise as to why, but there's more investigations going on with that. As of right now, more of an association rather than a pathophysiology. As for the choroidal folds, it's really important to have the dynamic scanning across the OCTs for the macular cube, just to really see those folds. We're presenting static images here, so it's not as easy to see, but they would really see those undulations in the Haller's layers when you're scanning across or up and down on the 5-line rasters or the macular cube images.
Are there any closing comments from Dr. Yang, your team? I think we can. I think you guys have done an excellent job covering things. It's very interesting to see how things evolve year by year. All of this is very hot off the presses news, and appreciate very much this update in this condition.
Honestly, what this reminds me of was when I was in med school, they told us that 50% of what you learn is going to be obsolete in 10 years. and you just don't know which 50% it is. And here we are, right? Like stuff I learned in residency is being reclassified, new diseases. It's fascinating. Thank you guys. That was an awesome session this morning.
Thanks, everyone.
Okay, have a good night or good day.